Okay, so we are streaming live on YouTube, so I think we should start now. Okay, Assalamu alaikum and good evening to all our participants who have joined us today on Zoom and who are watching us live on YouTube. We are also streaming live on our Facebook account. Saimaji will be streaming that live on our JK Scientists Facebook page also. We are joined today by two special guests from US. Dr. Mashood Ajaz Kakru and Dr. Bilal Ahmed Malik are joining us live. Today's session is second of its kind related to Doc to Doc, which is a special series from JK Scientists. So today's session will be specifically related to problems around cardiovascular diseases, or specifically we have kept the title as heart health awareness. Dr. Bilal and Dr. Mashood will be with us for around 1.5 hours. They will deliberate on different issues related to ischemic heart diseases, cardiovascular diseases, or more prevalent ones, the heart attacks that are more prevalent nowadays in the Valley of Kashmir. So Dr. Mashood Ajaz Kakru is an assistant professor in internal medicine at UC Health College of Medicine at US. And Dr. Bilal Ahmed Malik, who's our expert, is assistant professor cardiology at Maimonides Medical Center, Brooklyn, NY, USA. Thank you so much, Dr. Mashood Ajaz Kakru and Dr. Bilal for joining us today. Dr. Mashood will be the host for this event today, and Dr. Bilal A. Malik is our expert. Dr. Mashood Saab, the floor is yours. Please go ahead.
Thank you. Good evening, everybody. Heart disease kills about 9 million people in the world every year. It's the number one killer, and it just does not kill the people. It destroys the families. It destroys the communities. And when we talk about heart disease awareness, it is more about how do we prevent it? How do we detect it early? How do we treat it early so that the quality of life and longevity of life is maintained? We have our expert, Dr. Bilal Malik, and he does advanced interventions and is an expert in cardiology and more importantly, coronary artery disease and heart attacks, which is really the huge burden of cardiovascular disease. And I would like to start with asking Dr. Bilal Malik, tell us what happens during a heart attack, and how can somebody recognize that they're having a heart attack?
Thank you for having me. So heart attack is obviously the commonest and still the leading cause of death in this country and the world. Everybody, like even if you are a 12-year-old or 20-year-old, has some amount of plaque in your coronary arteries. One of the studies done in soldiers who were killed in the Korean War, and their autopsies had showed that they all had blockage in coronary arteries. So that does not mean that everybody gets a heart attack. So it's how I usually give an example is that if you go to buy a new car in a showroom, it is glistening and beautiful outside. You might take as good care as you want of it. It's never the same again once it's on the road.
Right.
The same way the coronary arteries are pristine once you are a newborn. As you grow older, some amount of plaque buildup is there, and depending upon how you treat yourself, if you have diabetes, if you have high cholesterol, if you have family history, that burden becomes a little more than usual if you smoke. So these plaques are always there, but the key factor is that one of those plaques sometime decides to rupture. When it ruptures, it exposes the endothelium, the inner part of it, and the blood clot forms. And when the blood clot forms, depending upon how much or how big a clot it is, if it blocks a partial artery, it's called an ACS, an on-ST elevation MI. If it blocks the whole artery, it's in complete ST elevation MI, means the real MI of the heart attack, which most people know of. That is the pathophysiology of it. Now the question is, why do these plaques rupture? And what brings that rupture? So it's a very controversial topic. Nobody knows exactly. There is contributing factors like stress, hypertension, situational issues, obviously drugs like cocaine and stuff, which make it happen, or just not taking care of yourself in general. One of those plaques may rupture. And plaques which have a thin cap rupture more often than thick cap. How do you thicken the cap of a plaque is usually people who are taken well care of, like who have high cholesterol and take statins and stuff, this plaque, the cap thickens and has lesser chance of rupture. So once it ruptures, then it's a vicious circle and depends upon how far it goes. As I said, if it totally closes, you get a heart attack. Now, what are the symptoms of it? The calmness, probably the easiest symptom, is acute chest pain. How we grade it, 10 out of 10 chest pain, like an elephant sitting on the chest, heaviness in chest, with this pain goes sometimes to neck, to the left arm. So that's classical heart attack. But unfortunately, not everybody has those symptoms, especially if you have diabetic, you may not have those symptoms. You don't have the pain sensation. So diabetics get what are called silent heart attacks, and people don't even know. And the only sign they may have sometimes is they feel shortness of breath, they may feel sweating. And sometimes they confuse with their sugar is low and stuff like that. So these things are not 100%, but if you have that heavy sensation, which I think is probably the best way of getting a heart attack, at least you get recognized. But if you have signs which are not very clear cut, even elderly, they may not have chest pain at all. They may just feel not feeling well. That's good enough. Feel weak. So sometimes it takes a little bit to tweak what it is, but getting an EKG, getting cardiac enzymes and stuff helps to determine what it is.
Well, in the United States, heart attack happens every 40 seconds, and about 50% of them never make it to the hospital. They have a sudden cardiac death or cardiac arrest. And if we take like similar, I don't have statistics from Kashmir, but if we like match it to the population, so like what I'm hearing is that like if we do recognize this early, there is an opportunity to save about 50 lives a day, even in Jammu and Kashmir, based on if there is a better awareness, better access to care, there is an opportunity to save more lives. And in Jammu and Kashmir, there is like a lot of confusion between the heart attack, heart failure, and cardiac arrest. And they are used interchangeably, yet they are different. They may be connected. Could you educate us more about like what's the difference between the three and throw some more light on that?
See, this can be confusing everywhere. Like heart attack, as per se said, is blocking the artery of the heart, leading to no blood flow into that area of the heart. That's a heart attack. Classically seen with chest pain, tension pain, sweating, losing consciousness, stuff like that. Heart failure is the heart, the muscle of the heart, not functioning well one way or the other. It could be the muscle is weak, or sometimes even if the muscle is normal, it is not able to pump all the blood which comes to it. That's heart failure. Heart attack in itself can lead to heart failure in the longer sense, but it's a more chronic disease. It's a longer term thing that heart does not function well, with whatever the cause is. And commonest cause is coronary artery disease. Commonest cause is blocking of the arteries of the heart, but hypertension, diabetes per itself, other issues, electrical issues, and thickening of muscle, what's called diastolic heart failure, especially in females. Those are other causes of heart failure, usually mentioned around. They have shortness of breath, swelling of feet, stuff like that. That's heart failure. As I said, CAD itself can be a big cause of heart failure. And cardiac arrest is a very mixed bag. And unfortunately, this was a concern that the young people have been dying back home, and what is the cause of it? I was just talking to people back home as I was there, and I just spoke to somebody before this meeting too, to see what are the causes, what happens with these people. See, if they were dying of heart attacks per se, heart attack meaning closing the artery of the heart, usually the drugs which cause that are stimulants like cocaine and stuff. I am told somehow it's not available in Jammu and Kashmir that commonly as other drugs are. What common drugs they are available are heroin and chairs and stuff like that. And cardiac arrest or heart failure or deaths from them usually are not from heart attack, mostly are respiratory depression, because it's to kind of cause respiratory depression that causes death. It's in the end, heart also stops. That's how people die. But it's predominantly not technically the technical term of heart attack. It's a cardiopulmonary arrest, predominantly a pulmonary arrest. And that's what causes their death, unfortunately. But if you were stimulants, if If you take cocaine, you can get heart attack in 15 minutes. Yes, that's a different drug, different mechanism. But these are not interchangeable terms, but these are more technical issues. So simply heart attack can be.
What we're understanding is that heart attack is not the only way how a heart can fail. There are a number of other reasons. Somebody with uncontrolled hypertension, somebody with bad diabetes, somebody with other kinds of heart disease can lead to heart failure as well. And cardiac arrest is a totally different mechanism. And although one of the common mechanisms is like having a heart attack, but there are other reasons for that. And that is the, we saw recently youth increase in the youth incidence of these events. One of the challenges always has been like, when I try to understand is that we have been, as a society, as a community, we have been very reluctant to autopsies. And sometimes when these deaths happen, and autopsy is sometimes the best way to figure out, what was the cause of this death, and we don't get that information, that data, and that probably prevents our effort to better understand why is the disease happening, or why these young people are dying. Do you agree with that, or you have a different perspective?
No, I totally agree. I think like now it's been kind of some maybe it's cultural, maybe it's religious, maybe it's social, whatever, that we're very reluctant. No, we consider whosoever passes that no, it's sacred now, don't touch the body anymore. But especially these young deaths, it's imperative we know what the cause is, because there might be something else. We are kind of shooting in the dark when we're blaming, okay, I just blamed cardiac depression because of these drugs. That might not be true. That might be just part of the story. They might be really getting more heart attacks, and there might be something else causing it. So it might be better off to kind of straighten out. And if we can get that awareness in the community that now, yes, to know exactly what is causing, that is the only way. There's no other way. And obviously, history of drug abuse is kind of a taboo, even here, not to say back home. And people don't give that history often. How often do we do urine tox and stuff? I'm not sure if they need a consent to do it back there. Yeah, you need a consent to do that. Right. That may help at least to detect a drug and stuff. At the same time, to relate them, what caused it, autopsy is definitely the only way to know the cause of that death. Even like if somebody makes it through what exactly happened, it might be helpful if we do proper investigations, and urine tox and stuff are very important. But what you pointed out, that awareness in the community, I think some of you might know, there has been this program, Save Heart, and there are physicians all over the whole state. They use WhatsApp to send the EKGs when they get a patient in their sub-district hospital, whatever, and send EKGs out to cardiologists, and they read these EKGs and kind of direct them, okay, this is a heart attack, this needs a blood thinning medication, a clot bust and stuff. And they have saved a lot of lives. I'm really, really happy that they have been able, even picked up some arrhythmias, VTs, SVTs, and I'm very glad that people for flung areas are able to do that, and they have availability of those drugs there, at least to treat by the time they reach a main hospital.
So coming back to the heart attacks, and not everybody is at equal risk of heart attacks, right? So there are like risk factors that lead to a heart attack, and some of these are we can't change, right? We can't change our parents, so we can't change our genetics. We can't change our age, right? We grow older. We don't have any control over it. But a lot of the risk factors are also preventable. And Kim Williams, the past president of American Heart Association, once said that I don't mind dying, but I don't want to be the reason for that. I don't want to be myself be the reason for that. And so these risk factors, could you educate us more about the common risk factors and what people need to do to identify them and to keep those things under control or prevent those things?
See, what you put it pretty well. Like there are modifiable and non-modifiable risk factors. See, as you mentioned, non-modifiable risk factors, your age, your sex, your genetics, that's done. Whatever you are, you are. Now, the modifiable risk factors are many, and some of them you still can have some control over, and some may not. See, smoking is a big factor. If you have diabetes, you can control diabetes better. That definitely has a better chance of doing better. If you have high cholesterol, as I said earlier, statins still are the mainstay of treatment. And if you take them, if you fall into those areas, your cholesterol is that high that you need to take a statin, you should take a statin. And again, there's it now. I'm not a smoker. I have no family history. My cholesterol is high. I've been on a statin for 7, 8 years. So that's when my patients think, oh, what about the liver problems? What about those problems? They're all sometimes there can be, but still they are still something you can look forward to and check them if at all that happens and can be modified. So these are the mainstay things which, again, these are very, very important things to take. And then exercise, weight is a big issue. If you are in good health, say, take an example. If you have a patient in an office and somebody who's 450 pounds and somebody who's 160 pounds, 10 years later, who do you expect to see there? 450 pounds.
Yeah, somebody with
simple as that.
160 pounds, yeah.
So these are, again, sometimes weight loss is a big issue, and how that can be done. I was one of those who was very reluctant when these GI surgeries were not great. Now they have incredible surgeries. They do incredible results. You can reverse even early diabetes by then, because people have diabetes because of their weight. And once they lose 100 to 100 pounds because these surgeries, their diabetes is gone for 5, 10 years. Now it's a different world. Your perspective to life changes. But this is a matter of kind of education, community service, and putting it back there. People don't take it as a taboo. Here, people do are very cosmetically aware of it, and it's available. But despite that, when it starts hurting your body, then you better take care of yourself. And again, exercising every day, whatever, you don't have to it's probably, if you go to gym and stuff, if you just walk for an hour or so every day, brisk walking, that's good enough most of the times.
So like you said, weight management is an important, should be an important goal. And being sedentary is twice as deadly as at least walking 20 minutes a day. So is there any recommendation about how much exercise is beneficial? Is there something called too much exercise or too little? What's the optimal level of exercise that can maintain a cardiovascular health?
Anybody with CAD, the recommendation is 1 hour a day for at least 5 days a week. 1 hour a day, brisk walking, which brings sweat out. It's not just walking with a dog and roaming around. Brisk walking, which makes every body muscle work. You sweat a little bit, that kind of thing. That's the recommendation for CAD people. And is there anything? In fact, you're interesting. Somebody asked me in an elevator yesterday, one of the couriers in the hospital, because it looks like he's a big muscle guy, works around dark. What about, is it too much if I work too hard? I said, no, you are 20-something-year-old. You can work as hard as you work. But there is a condition called athlete's heart. People who are very high-end athletes who work too hard and their muscles the heart muscle gets thickened and stuff. I don't think most of our people are in that range anyway. So that's probably not to be worried about for them. But you can do as much exercise as you want. That's totally extreme exercise. And even then, if done properly under proper supervision, that might be okay. So I don't think that should be a worry for most of our people. They can do as much exercise as tolerable. See, if it's using common sense. When you're running and you get short of breath, there's no point killing yourself and running when you can faint. Now, if you're getting chest pain doing it, stop it. That means that's your limit. Now you got to figure out what's going on.
Yeah. So one of the other components of the weight management is diet, right? And in Kashmir, our diet has, it's very tasty, right? Every time I go there, I don't leave any home without a little bit of wazwan. What are your thoughts about the diet we use and its effect on cardiovascular health, salty, wazwan, or a lot of red meat that is a more of a dietary pattern there?
I think like no, even too much of rice, high amount of carbs we take,
Yeah.
that's a bigger problem. Like no, and meats, the way we cook them, like no, the way we fry them and stuff like that's a bigger problem. Like no, if you have fried food, that makes it much higher risk. Like we advise our patients to eat a lot of fish and tuna and salmon. But if you fry the fish, it kills the whole idea of eating fish. So if you eat them well, if don't fry in this, one of the oils, if you have to use some amount of oil because people just sometimes cannot live without some oil, extra virgin olive oil, the extra virgin olive oil is probably a little bit of it is the best thing to use. If you have to use oil, if you can do without oil, now there are these air fryers which have made the whole difference that you can use minimal oil and get that fried look of the food. That probably will change a lot. Salt, extra salt, because a lot of our population is hypertensive to begin with, and drinking salty and remaining uncontrolled hypertension is never going to be helpful. Meats, I don't think most people eat a lot of meat there, but yes, every day they eat a little bit of meat. Fatty food meat, especially Vazwan, if you, especially in the season, you eat a lot of it, it may not be helpful. It's definitely not. Tabak mas, as tasty as it is, it's direct to the coronaries. So I think once in a blue moon, everything is okay. But if you make it a habit, it's going to come and hurt you. I use this term often. Like now, when pleasure becomes a habit, it ceases to be a pleasure. So that's the problem.
Yeah, I totally agree. So there's a lot of debate about the eggs. Like there's a lot of debate about egg white is better or not the yolk. Yolk has a lot of cholesterol. And yeah, what are your thoughts about that? Should people be like, is that cholesterol bad? Does it the one that's in the egg yolk, or how should people take eggs into your diet?
See, people who really love eggs, they will show you a ton of research that no, egg yolk is not that harmful, this and that. It's back and forth. To make it very clear and simple, probably the safest thing is just taking the egg white is the safest thing. Can you have enough research to prove this is not too bad? Probably is not terrible, but may not be the right thing to do. So if you have to make it simple, if you have to eat eggs, egg white is the best thing to eat. Egg yolk definitely does have high cholesterol. Like any other things with high rich cholesterol may not be very helpful to make it simple. Otherwise, no, it will make more controversies.
So we're going to do like a small rapid fire round here. If you have to pick a hot, healthy diet, so like red meat, like lamb versus chicken, what will you pick?
Chicken, obviously.
All right, well, chicken versus fish.
Fish then.
Fish, yeah, okay. Fish versus there's some other source of protein like dals and there's some proteins from the plant source.
They're pretty good, but fish, especially tuna and salmon, they are really, really good in raising HDL. So that gives them a huge advantage. Like you just have to be careful. Sometimes people, I know somebody who eats salmon and stuff 3 to 4 times a week, and then they get mercury poisoning. So you don't have to go crazy that way. But if you eat a couple of times a week, it's probably healthy. And the way you eat it, you don't have to fry it. Grill it, do it that way. That probably is the healthier way of doing it. Now you see, like especially what our eyes don't catch that high use of triglycerides. High triglycerides is probably natural to most of us. Some of it is dietary because we eat a lot of rice and stuff, and some of it is genetic. Genetic hypertriglyceridemia are very common with us, and we all have low HDLs to begin with. So if you come down on your rice eating, increase your fish, exercise to increase your HDL, which is protective, that really makes much more sense.
Yeah, I totally kind of agree with you. Like salmon is my favorite as well, but yeah, don't take too much of it. Yeah, I think like moderation in everything. Don't go into extremes. Like if there's moderation in most things, mostly they go well with your body.
Is a cardiologist. He says he hates salmon, but he somehow takes it anyway. He feels like he's eating medication. That's how he takes it. He says it looks like, I'm eating medication. The salmon is part of it too.
All right.
He puts that.
Now coming back to, we went over what the heart attack is. We went over what the risk factors for the heart attack is. We went over hopefully like with some symptoms how to recognize it early. Even before having a heart attack, what are the 3 common tests so we can people go through in the hospital to detect if they have that block built up in the coronary arteries?
See, one of the important things is screening tests are very good, in general. But who are the people who should be screened? Should it be randomly done, and depending upon people's insurance, people go crazy. But if somebody is doing good exercise, eating good food, a basic screening of everybody should be a lipid profile, see where the cholesterol is. You check a hemoglobin A1C, especially his family history of diabetes and stuff, where the sugars are, because that kind of builds into your risk profile, obviously weight. Mm-hmm. So if you see a hemoglobin A1C is high, there is high cholesterol, somebody is 45, 50-year-old, it might not be a bad idea if he's not exercising aggressively. If somebody is running a marathon, half a marathon every day, he doesn't need any more tests. He's fine. If his cholesterol is okay, his sugars are okay, and he's doing that great, that's fine. But most of us don't. One of the easiest screening tests is doing a stress test, a regular stress on a treadmill and see. In fact, anybody 45, 50, if you have to join a gym, technically you should have a regular stress test before doing it to make sure that you are good enough to go join a gym. It's not too much stress on you. And that if you do very well, 9-10 minutes on the treadmill with no chest pains, no on a stress test, not the regular treadmill, because there's a protocol you follow, and EKG is normal, likelihood of having CAD is minimal. As I said, if you go crazy looking for do a CTA and stuff, you will find plaques. And depending on how good an operator is who looks at it, he will say, I did an angiogram yesterday. Even in this country, somebody had red plaques here, there, everywhere. He had disease, but only at one area. It was not everywhere. So if you go crazy looking for it, as I said, plaque buildup is part of your body as a natural thing. You have to be somebody very good to really find it on a CTA and stuff to the exact level. And people overread it, and then people become very concerned. So you don't have to go crazy looking for stuff if you're doing everything normal. A regular good exercise test should be more than enough. But if you have high risk, or if you have family history, if you have symptoms, then obviously you got to go further. That may not be good enough with medications on board.
You touched on a really important thing here, family history. And, family history is something that worries me a lot if somebody has a family history. So could you throw some light on what premature coronary disease in the family means in men and women? And if there is a family history, what should these people do to reduce their risk of developing a heart disease?
See, by definition, family history of early CAD is if there's a male in the family who has had a heart attack before 40 years age, and a female which has had a heart attack in the family before the age of 50. That's by definition what family history of early CAD is. And if you end up having that, if you're having your uncle had a heart attack at 38, your other uncle had a bypass at 40, then you obviously run a very high risk of having CAD. I had a family, there was not a single male who had lived more than 43 years of age. They somehow get a heart attack and die by that age. There's only so much you can do to prevent these things. But as we said, there are certain non-modifiable risk factors like the history. But if these people are diabetic, if these people have high cholesterol, if these people are obese, if these people are smoking, you can prevent that, you can control that. And if that all is prevented, then the rest is leave rest to God. But these things are important. Their cholesterol has to be more aggressively controlled. They have to be managed as if they had CAD. Goals of LDL have to be very aggressive in them. Goals of sugar control, goals of blood pressure control have to be aggressive in them. They should lose their weight. They should have good exercise. That will really matter. And you'll be surprised, some of them, when you get to know their family history, you say, oh, but he was smoking 2 packs a day as well, and he died at 40. So it's not just family history is part of it, but the person who had a heart attack and who somehow died of it may have more to add to that just not the genetics, because obviously genetics as of now, you may not be able to change it. Hopefully down the road, you might be able to manipulate it, but right now there's not much you can do about it, but you can modify the modifiable risk factors to serve you best.
Yes, this program is about awareness. If you go back 50 years, the prevalence of smoking in America was 50%. And through all these efforts to increase the awareness, now it's down to about 20%. So awareness really helps to identify and to kind of be aware of these risk factors and try to avoid them, avoid these things. Coming back to what you said, not everybody needs to be tested, and I think it goes back to everything we do in medicine is for two things, right? So our two goals are: can I make this patient feel better? And the second goal is, can I make this patient live longer, right? And if we come back to coronary disease, if it's not causing them any symptoms, so I don't think you can make them feel better, because even if you identify coronary disease, you cannot make them feel better, right? And the second thing is that even if you find a coronary disease, you fix it, it may not necessarily make them live longer. So what I understand from from our conversation is that it does not we don't have to go after screening everybody except somebody in the high risk or somebody who has symptoms.
No, that's incredibly true. Unfortunately, that is when this, see, as much as I love stenting, that doesn't mean everybody needs a stent. And it's sometimes very hard to hold back when you see somebody's artery just blocked this much. But if he has absolutely no symptoms, you're not going to improve anything. And stents, even bypass surgery, does not prevent a heart attack. It's very clear, very, very clear. None of the stents, none of bypass surgeries prevents heart attacks. Yes, it opens up arteries, it keeps them open. In fact, with stents, you need medications to keep the stents open. So if you mess up on medications, you may have a higher risk of getting a heart attack. So it does not save you. Yes, it prevents, it improves flow and stuff like that, but it has to be needed. That's why I am personally against blindly screening people aggressively. If they have absolutely no symptoms, they're exercising. As we discussed, that even 20-year-olds can have coronary plaques. So can 70-year-olds, so can 50-year-olds. If they're not causing any symptoms and you're controlling their cholesterol, your plaques are kind of, as we said, we thicken the cap of the atherosclerotic plaques, making sure that risk of their rupturing is low, you will be fine. So if it's not broken, there's no need of fixing it. So that has to be, it has to be borne in mind. So sometimes that becomes a very, very contentious issue. I did an angiogram, you have blockage, you need to be fixed. Meanwhile, I have a ton of patients, even in leg disease. I can tell you at least I have 15, 20 patients who have bilateral SFAs totally occluded. One of them is a work manager. He walks 7 to 8 miles a day. What do I tell him? I still need to open it.
If they're not symptomatic. And again, if you do put them through high risk interventions, you have to have some benefit out of it. If they're not feeling bad right now, you're not going to feel any better later. So it comes back.
I want him to run a marathon at the age of 70 now. So it's unfortunately, it becomes a lot of other issues come in between. There's a lot of ethical issues which come in between. There's a lot of insurance issues. We don't need to go into that. We'll hold the medical part of on it only. But again, doing the right thing. I'm very impressed that people back home, I work closely with both doctors at SCIMS and lots of times in SMHS also. They're very bright people and I'm very proud of them. They do right things. They by the book most of the time. It's very heartening to see that.
I was just recently in SCIMS. It's impressive, how much they have improved and developed compared to when I was there last time. The speed of progress may not be they may not be where developed countries is right now, but I think they're trying to do the best they can for the communities there, for the families there. Coming back to the medications part of it, a lot of people tend to take baby aspirin. And, and in technical terms, primary prevention versus secondary prevention. Could you like educate us a little bit about who's a good candidate for a baby aspirin, or is it always helpful?
So if you have underlying CAD of any kind, meaning you have had a heart attack, you have had a bypass, you have had a stent, you have had a non-ST elevation MI, and a blockage is baby aspirin is absolutely fine. There's no problem with it. If somebody gets screened, he has carotid plaques of significance or peripheral plaques, even if they're not blocking and stuff, baby aspirin is probably fine. But giving randomly baby aspirin to every 60-year-old, 50-year-old, we know that now they end up bleeding more and stuff like that. They have more complications, especially small little females. They may end up having more bleeding complications. As long as you have a genuine reason, some people are now, you have to have some amount of plaque burden somewhere, hypertension, diabetes, cholesterol, risk factors like that. Then if you qualify for having a baby aspirin, that's fine. But randomly giving baby aspirin to people may end up hurting people than anything. It's not needed for everybody.
And when somebody gets a stent, like a lot of times, like we tend to play doctor and try to stop the medication off our own. And one of the very important things when somebody gets a stent is that they have to be compliant with the medications. Could you throw a little bit of light on that and why that is very important and after you get a stent?
See, stent obviously is an outside device. Now, even the medicated stents and everything else, it's a device putting in. Till the time it gets endothelialized, means a fresh layer of endothelium comes over it, it's a rough surface opening up to blood. So you need what's called dual antiplatelet therapy, aspirin Plavix, aspirin Brilinta, aspirin Prasugrel, at least for that time. Duration of aspirin is lifelong, no question about it. Now the question of other medications, Plavix and stuff. There are trials to show that in high-risk patients, 1 month is good enough, 3 to 6 months is good enough in most patients. That's true, but there are issues. Meaning, if somebody came with a heart attack, be it ST elevation MI or non-ST elevation MI, yes, for protection of that stent thrombosis, 6 months may be good enough. But if they have recurrent events, if they have plaques in other areas, 50% of those MIs occur on that stent and 50% occur at elsewhere, so other places. So what I tend to do is, like if I have a younger patient who has less risk of bleeding, I will tend to keep it for more time. For Brilinta, usually 1 year of 90 milligram twice a day. After 1 year, we decrease it to 60 milligram for 2 to 3 years. And then kind of I use my common sense to risk benefit. Now, if I have an 80-year-old, I have a 90-year-old, I'm going to stop it. If I have a 50-year-old whose hemoglobin is 15.6, never had a GI issue, there's no point. Let him have it. What's the big deal? It's going to be protective. But after a year or so, you may not need dual antiplatelet therapy. Aspirin may be good enough. And there's a lot of data now that aspirin may not be needed. You can either do Brilinta or Plavix, that might be okay. But some kind of antiplatelet, at least one antiplatelet needs to be there once you have different CAD. That will give an interesting.
Coming back to the testing, one of the things I recently came to know is now the coronary CTs are available in Kashmir as well. And, one of the screening things is stressed as one of the screening things is a coronary CT. Could you help us understand, like, are they both equal, or what helps us understand heart disease better?
See, there are two aspects of it. One is an anatomy. Other is physiology, is that right? Anatomy, CTA is a great thing. It will show you has plaque there, and whatever. Right? You get the anatomical picture of it. As we discussed before, is that plaque significant for that patient? Is it giving him any symptoms? Is it worth going after? So if it's a 90% blockage, then probably yes, if he has symptoms. But the question is, any physiological test, a stress test of any kind, exercise test, exercise nuclear, stress echo, gives you a physiological variety to it. But we understand they have plaques. Are they giving less blood flow to that area? If they're not, if patient is not symptomatic, you can have plaques as much as you want. If patient, as we discussed, has no symptoms and is not restricting activity, he does 12 minutes, he walks 10 miles, 5 miles, 4 miles without any issues, there's no point fixing it. As we said, you cannot make him better. And there is no guarantee you're going to prevent his death by doing a stent or bypass surgery. At that same time, if you start him on an aspirin, start him on a statin, control his blood pressure, if he's diabetic, he should be on an ACE inhibitor and stuff. Those things will prevent, those things are going to prolong your life, not putting in a stent. So
Yeah,
it's kind
right.
of-
What we understand is that like a CT scan tells you the anatomy. It doesn't tell you whether that anatomy is giving you symptoms or not. While if you do a stress test, you got a physiologic data, right? You can see if they reproduce their symptoms, right? Whatever symptoms they have on a daily basis, can they be reproduced at the time of stress test? Does the EKG change? And then if you add an imaging modality like a nuclear stress test or an echo, you can also see like if there's different segments of the heart muscle working properly or not.
Exactly. And there is on CTAs, there's one technology called CTFFR. It's available in this country, but there's only one company does. You have to have a contract with that company to do it. You can do a fractional flow reserve or that lesion with the CTA also. It's not available. It's available probably in Israel also because it's an Israeli company. But not many people, even our hospital does not have a contract with that company because they want everything just for themselves. That will give you physiological assessment if you are that advanced with the CTA. But otherwise, CTA gives you anatomy, but does not help you with physiology and managing.
Yeah, so we talked about, how to kind of recognize the symptoms, how to detect a coronary disease before the heart attack happens. Now, there's also like when the heart attack is actually happening, and there's a term that is used, time is muscle. Could you help us understand the importance of time here and why in the United States we tend to open the artery within 60 minutes when they hit the door in the hospital or within 90 minutes from their symptom onset? Why is that so important in terms of like helping them live longer or leave them with less disabilities?
See, it's a very clean cut. Like now, if you have a heart attack right this moment and the artery gets closed, it takes a couple of hours for muscle to totally die. So during that time, it remains partially viable. Sooner you open it, you will have normal heart valve function. You will have no damage to muscle. As the time progresses, you will have more and more damage. If you open it now, there's a trial here by the name OAT trial. They said if you open an artery after 3 days of its closure, it's harmful and not beneficial, which I don't personally believe in. That's a different story, but is that bad sometimes? So within first 12 hours of having a heart attack, you still have good chance of opening up. That's why even thrombolytics are indicated within first 12 hours of doing it. So sooner you open it, more muscle you save. More muscle keeps on dying as the time passes by. Here, door to balloon time is considered around 60 to 90 minutes, and most people make it earlier. But what you forget lots of times, even here, is when did the pain start? So person came to ER right now, but his pain was 4 days back. What does it help now?
Yeah.
No. Now
they already completed the heart attack.
The whole world is up. No, it's kind of silliness, but it's just kind of establishes how important it is. But at the same time, one of the first things you ask the patient is when was the pain? Pain was, I get really scared of doing something which was that old because if you have pain, which is called post-MI angina, that usually is a harbinger of something more dangerous. You may have mechanical complication because you lived the heart attack pain. Now you may have VSD. Now you may have cardiac rupture. You might have a papillary muscle rupture. So that is a dangerous, dangerous time. If it's been 4 or 5 days back, that can be even much more dangerous. Giving a thrombolytic or taking him to lab. But anyway, sooner you open up the artery, obviously better you have results and better flow you achieve once you open up the artery. See, we monitor flow of an artery per TIMI1, TIMI2, TIMI3. TIMI3 is considered brisk normal flow. If you're able to attain that flow at the end of the procedure, your mortality is 1/4 the mortality of if you have TIMI1 flow or more. So that's how important it is. Sooner and brisker flow, better myocardial perfusion, better life. That's
and in Kashmir there's all there's still like a lot of these heart heart attacks are treated with the thrombolytics versus, doing primary PCI where you open the artery quickly. Could you help us understand if the one is beneficial over the other, and should be done more often?
See, if primary PCI is available within 2 hours, 3 hours, it probably is better than thrombolytics at all the times without a question. Because thrombolytics, as good as they are, they run a risk of bleeding, right? So at least 1% risk of intracranial bleeding. And depending upon the age of the patient, if it's an 80-year-old, 90-year-old, your blood risk of bleeding runs much, much higher. If it's a younger patient, your risk of bleeding is pretty low. But if you're an older patient, your risk of bleeding is much, much higher. And again, thrombolytics again work when it's short duration. If duration of pain is 6 hours, 8 hours, the efficacy of thrombolytics goes down automatically. Thrombolytics work on fresh clot only. See, I give this example to fellows all the time. When you have PE, unless you have acute massive PE, you don't thrombolize anybody, right? You give them heparin, whatever, enoxaparin, but not thrombolysis, because it does not, most of the PE comes from DVT and clots. It's an old clot. So thrombolysis would not work on that. But why do you give in massive PE thrombolysis when patient is dying? Because you just want to open that fresh clot around it to make some space for at least blood to go in. Because old clot, it's not going to do much about. So thrombolysis works on fresh clot only. If again, pain duration is 12 hours or more, thrombolysis has minimal role whatsoever. But if you have chest pain, persistent ST elevations, you still give it, because lots of times you are not sure when exactly did the artery close. So you can have pain day before, you had pain more yesterday, now you had pain more. So artery might have closed today, what's called a stuttering MI, that it was there for a day or two. So you don't sometimes base it on duration of pain, you base it on when was the most severe pain. If the severe pain was 2 hours again, early, then time probably thrombolysis will work pretty fine. But if you have
what I understand from this is that the heart attack can be happening over a period of time, and it may not have completely blocked the artery. And once it completely blocks the artery, that is the very critical time where you start, the clock begins from there, and you really need to open the artery from that point on, right?
But if you have PCI available, it will supersede thrombolytics all the time.
Like I said in the beginning, heart attacks are bad. They not only kill people, if people survive, they can, and they don't get it treatment in time, they are left with significant disabilities in terms of how far they can walk. They can get chest pains on a regular basis based on what's the residual disease. We had I'm a cardiologist. My brother just finished the cardiology training, and my brother-in-law is a cardiologist. And the reason I'm saying this is that, although we have three cardiologists in the family, we still could not prevent heart disease or heart attack in my dad last year. So my dad had a heart attack, and what was very important was, we talked about his chest pain. He did not have chest pain. He had some nausea, some vomiting, and some diaphoresis, like the sweating, and at 4 a.m. in the morning. And it was an Eid the day before, and there is a lot of tendency to blame it on, you ate something bad the day before, and not go to the hospital. And my brother-in-law, Dr. Amir Rashid, he's an interventional cardiologist in skin. So they called him, and he was very quick to respond and got an EKG quickly and had ST elevation, and took him to the skins. And I think that's the fastest I have ever seen some intervention done in Kashmir, but it still took about 3 hours from symptom onset to when they had to open the artery. And luckily, my father was not left with any residual damage from the heart attack. But the reason I say the story is that don't ignore your symptoms. Although he did not have chest pain, which brings me to other area of heart health, is that there are diabetics who may not have chest pain, but there's also, like our woman in in our communities, we pay less attention to them. We almost see heart disease as a disease of man, while the heart disease is also a number one killer in women, and more importantly after the age of 40, and more so if they had some issues with the pregnancy, with the gestational diabetes or eclampsia or hypertension. So could you educate us more about like how symptoms in women can be different, or it may not always be the chest pain. Sometimes they can complain of toothache or back pain, or like it can be some. So why does that happen? Why do women have different symptoms than men?
See, one of the things is, as you mentioned, with your dad, unfortunately, he had this nausea, vomiting. That's typical presentation of an inferior wall MI. Like, no, you have, you feel, that's why sometimes, heartburn is called heartburn. You feel that GI thing, but it's not. So it's sometimes very difficult even to tease in the emergency rooms, which is which. And somebody has to be curious now, get an EKG, make sure, put two and two together if that is going on. And most of the times we're lucky enough to figure it out, but sometimes it can be really totally difficult. People keep on giving them GI cocktails until enzyme comes up 20 and 30. Now everybody looks at the EKG, oh, you missed a subtle ST elevation. Or if it especially is a silent EKG also, if you have SIRC-OM disease, you may not have major EKG changes and you have inferior wall MI. So that's a big problem. Coming to women, and it's our communities are no different than in this country also. It has been a big problem in this country that women and heart disease has been under-recognized. Before menopause, estrogen protects against CAD, no question about it. The younger women who are menstruating have much lesser coronary artery disease per se. They may have other issues, but not coronary artery disease. But after menopause, they catch up fast and end up having the same risk, or if not higher risk, than having heart attacks. Symptoms of women, are they just overlooked because they are women? Sometimes yes, like that may be an inherent bias in the system that you don't feel like, oh, because previously, as you mentioned, it was always thought this is a man's disease and not female disease. So it's a GI symptom, it's something, don't worry about it. But yes, it's true, like elderly people, women do have some specific symptoms which are a little different than men. And common thing is the pain going to jaw, neck. If the pain goes to lower teeth and jaw, it's usually angina. It's most often may be a very high risk angina. And rest, the same thing, not feeling well, uneasy, nausea, vomiting can occur in either way, but they do have sometimes atypical symptoms, and pain may not be very typical. It may be because of their genetic makeup or whatever, but sometimes I believe women are kind of the stronger species, and they bear pain much better than men do, and they don't complain much, and somehow they get overlooked. That's a fact of life even in this country.
There are a lot of like initiatives. American Heart Association took, like there was Go Red for Women that started in 2005, and then by 2012 they saw like there's like a reduced incidence of heart disease in women, and there was like a number of other awareness campaigns that we run here. I think that's lacking in Kashmir. What are your thoughts about how we can bring better awareness about, hey, heart disease is not just the men's disease, the women are equally can have the disease as well.
The good part is that now it's very heartening to see our younger generation growing up in a much better environment, and our younger females, our girls, sisters, daughters doing very, very well and having a ton of education. And that probably changes everything. The basic problem and most problems in the world will be solved if education becomes a predominant thing. Yes, it has changed a lot. It's getting better and better. It will take some time. We have our own culture and other issues and societal issues which push us back a little bit. But despite that, I think we have made tremendous progress. And every time I go, I feel like we are moving much faster than even this country in education. And kids are doing great. And these younger kids, how to spread the word around. social media is huge. Whatever it is, Facebook, Instagram, and stuff. There are borrowed messages which can be sent if you. I just saw a message about smoking prevention. Like if you want to have cancer like this, and it was very very impressive, like very graphic sometimes, but at least conveyed the same meaning. So we can put the same things like now. These are the signs of heart attack, and women are no different. Women have heart attacks too. The signs may be different. As much as you, social media can be used proactively to do it. I think that'll be really helpful, and that's the most important thing right now.
Yeah. As like a lot of our viewers may or may not know, Dr. Bilal Malik has been one of the pioneers and of Kashmir, which is Kashmiri American Society for Healthcare Education and Research. And one of the initiatives they have recently taken, I mean, like in the last few years, I guess, is that they have started like free ambulances in in different parts of Kashmir, and which brings us to important point: the time that is lost between the symptom onset to the patients reach the hospital. I think that your whole goal is, can we reduce this time? Can we get the patients quickly to the hospital so that we can save more lives, or we can treat them right in time so that they have a good quality of life left? Could you throw some more light on your efforts, and like what have been the common barriers or some challenges that you faced as you implemented these things in there?
See, as of today, our ambulances are working in Srinagar, Anantnag, Baramulla, and Kupwara districts now as well. And these are absolutely free of charge. These, when you call the number, I will try and share the number with you guys. If Zaidat, somebody can put, I will just put that poster up for you guys now. I will share so that you can put it up. It's just one number. It gets to, there is a physician who takes the call. You tell them the symptoms, and he kind of assesses if you need an emergency help, if it's a medical or a surgical emergency, and he dispatches the ambulance to your location, and you don't have to do anything. And these ambulances are equipped with everything. In fact, one of our ambulances is even equipped with a ventilator. They have EKG machines, they have defibrillators, they have IVs, they have medications of all emergency kinds, which can be given. And that means you're being treated. Your emergency room comes to your home to treat you. So that's different than having just a medical carriage thing, like now, wherein you can just be picked up and sent to emergency room or something like that. And we try to coordinate with emergency rooms as well, call them and, oh, you're expecting a heart attack and stuff like that. So emergency room is aware of that patient as well. So I'm kind of a little disappointed that it's not taken the same amount of volume or same amount of shape. Not many people are using it, but hopefully we can use more awareness campaigns like this program and other social media things to let people know of this number that to call. And we're trying to coordinate with even the government, if they can give us one of those special numbers, 107, 108, something like that, which may be a little more catchy for people, so that they can call that number and utilize the service. You don't lose anything. You get 2 EMTs who take care of you. They pick you up. They have all the facilities available, and they will drop you to the nearest emergency room so that you receive care. I think it's something which nobody else has. And there are tons of ambulances in Srinagar. These are more carrier vehicles than treatment ambulances.
You know, when I was in Columbus, there was an association, Muslim, it's called like Muslim Families of Ohio or something, and they were doing the charitable work as well. And one of the things they were doing is just making sure, like, or they're willing to help people, but they were trying to see like how they can get the best that is provided through the government first, and then like supplement or pay their bills and do all that, right? And from what I understand is that there may be like some some difficulty with the funds and other things, but there are some government funds available, and how can like Kashmir collaborate with the local agencies there and make sure that like the provided funds and resources are utilized to their maximum and then supplemented, rather than just like be the, oh, I will give the ambulance and like and run it and then incur the costs.
See, this is what we have discussed with government in detail. Luckily, government is fully aware of what we are doing. We're not doing it to kind of upstage government. We're working with them. They have their own ambulance system, which somehow they're not been capable of dealing with the situation. So we're a supplemental thing. We're not the primary thing. We don't have the resources as government would have, but this is an additional facility available. But somehow, even when we started at that time, only government had this 108 program, similar like this, but they have not been able to run it with EMTs and the ambulances which are fully equipped to this day. So as we said, our resources cannot compare with theirs. We are doing it at a smaller scale than they would if they really wanted to do this much. But we're trying to supplement it. The idea was basically based on, even in Brooklyn where I practice, we have a Jewish ambulance system called Hatzolah. Mm-hmm. It's a free ambulance system, and it works with 911, FDNY, and New York Fire Department, everybody. When 911 call comes, all the phones ring, and Hatzolah picks up the phone. If Hatzolah ambulance is nearby, they will tell them, listen, we'll go for it. That's fine. They go for it, other people back off. So that was the idea, that no, we're not going to supplement them. We're just going to supplement them. We're not going to take over everything. Right now, there's nothing working. If there is something, we're obviously not going to compete with them. We want to help them to help lessen the burden on the whole system.
And how much does it cost to maintain all these 4 ambulances for your organization?
Oh, it's a huge cost. Besides the cost of the ambulance, which is around $35,000, but maintaining ambulance, paying for the EMTs, the rents and stuff, costs us $20,000 in each ambulance per year. And this is a lot of money from all our donors here who pay from out their hard-earned money from their college funds of kids and stuff, because obviously we all love our home and we really want to contribute. And whatever facilities, whatever we have here, we want to see our people back home, if not have exactly the same, but at least grow up and have little by little to the same extent that we enjoy here. And that's the dream of everybody.
I have a background in improvement science and system thinking. And when I go back and I see like what you're trying to do is that, but there's also this, so when you think about system thinking, if you try to improve the one part of the system, it may not improve the whole system. Obviously, our goal is to how do we make the whole system better, right? And one of the important links coming back to the heart attack is like in having that awareness or training to do the CPR, to know how to use the defibrillator. Has your organization or any other organization that is operated that's operating there try to do the workshops for CPR? How we try to affiliate with the AHA to give them training and give them the required, the certificates for that they're certified by to do these things.
The good part is that we had Director of Health Services division used to run these programs over ACLS and stuff like that. So we're kind of trying to work with them. After 2019 August, the whole thing collapsed and we could not get them. Our physicians are all ACLS certified. Our goal is to make sure that all our EMTs are at least BLS and ACLS certified to do that. We per se we don't have the capacity to run ACLS program on our own because you need AHA certification. There are agencies there are with this division, Department of Health. There's a Guru Foundation also runs a helpful camp with them to run. They have all the ACLS stuff to run with their help, so it can be a certified program. They have run some before. Hopefully they will plan to run some later this year as well. In fact, we had suggested to SCIMS and GMC principals way back that as in this country, anybody who enters into residency should be minimal ACLS certified, if not ATLS certified as well. It should be part of curriculum. There is no reason it not to be part of curriculum. That any physician who's an intern or resident who's going to take care of his patients on his own should have an advanced cardiac life support training for sure. I don't think they have fully incorporated in their training yet, but sooner or later, I'm sure they will. But we're trying our best to make sure all our EMTs and physicians are at least ACLS certified so that they can run the whole thing.
Yeah, like there are a lot of like cardiologists from here that I know that they go there and try to help out and try to do the advanced procedures there. I know Dr. Kanjwal, both Yusuf Kanjwal and Khalil Kanjwal goes there. Dr. Mujib Sheikh has gone there. Previously, I know Dr. Suhail Al-Aqaband has tried to help out, but often like when people try to make effort from here, do you think it's always well received, or like how can we better help and not upset anybody there, like without stepping on the toes?
See, I have all praise for people there. I have been going for the last 8 years. In fact, I was there last week. I did a few cases in Institute of Medical Sciences also, and I have been doing them every year for the last 8 years since Dr. Khurshid Iqbal was chief of cardiology there. And then Dr. Nisar Trambu, Khurshid Aslam, all of them, and Khalid Mahideen from SMHS and Bashir Naik, they have been very receptive. Now Hilal Saab is the chief at SKIMS. Imran and Ejaz, I know very personally very well. They have been incredible. Like now, the whole ego issues which used to be there, they have been so well receptive and always welcoming. They're on symposia for us and whatever we want to do high risk procedures with them, which we find great joy in, and hopefully they learn something as well. They have been incredibly receptive, like to all of them. And the names you mentioned, they all go as well. And there are some other people besides that who previously had found difficulty in doing there. And I have been lucky enough to hook them up with the right people, and they have found incredible work. Like they enjoyed. I know Sarfraz Durrani went a year or two back, and he did some beautiful ablation cases with them for EP. He was glad that he previously did not have great experience. He said he was not well received. He was very well received. I think it goes to credit of all of them, both at SMH and SKIMS, how the mindset has changed and how good they are in receiving people from there and giving us opportunity to do things there, and themselves learn as well. It's all praise. I can't say anything. I have no complaints whatsoever. It's a totally different environment. I'm not sure how it is in different, it might be a little different in other departments or whatever, but I can say of cardiology for sure, it's been wonderfully received, and we are very proud of all of them.
You mentioned some important names as well. Dr. Khalid Mohideen, he has been my teacher, and he's like, I think he's one of the brightest people I have met in cardiology. Then you mentioned about Hilal, Dr. Hilal. I just met him this time, and very, very humble, very genuine, and was very welcoming when I visited the department there. Coming back to like the same thing about this collaboration. As a part of the UC Health, we're running a Rwanda project. We're trying to design a fellowship in Rwanda. Rwanda is a country in Africa. It only has 5 cardiologists, and there's a lot of need. And how we're trying to set that up is that there is like a cardiologist from US that will go there every for 2 weeks and train people there, and then come back. And there are a number of cardiologists that are willing to do that and take turns and design a fellowship there. Do you think there is a possibility of similar collaboration within Kashmir between the cardiologists from America, Britain, Middle East, or wherever it's outside, and the local cardiologists who are like really very smart and have like a really high clinical acumen there? Is there a possibility to collaborate and design some kind of training for future generations that can help us disclose this gap where the Western world is in the cardiovascular health and care, and where Kashmir is?
No, I'm sure they have been very receptive. Like now, we have done certain cases. They had certain machines that were not well used. We have used them there with them, and they've been great. And if they need help in progressing, that they don't have everything available, but within the resources they have, they do an incredible job. And somehow people still don't have faith in the system. Everybody likes to go to Delhi or wherever, Bombay, whatever. But I am very confident that these are very capable people, and given resources, given everything, they should be able to handle almost everything. And if they need any further training in them, they usually do get experts from Indian other parts also, with the companies bring them, and we all do whatever we can as well. And it should not be a problem. The way I have found them, how receptive they are, if anybody has any specific ideas, we'll be more than happy to work with them. And I'm sure they have no issues at all. They have been very receptive that way.
Great. One of the things that we wanted to talk about is people of Jammu and Kashmir have been very resilient. At the same time, when you are very resilient, you also have a lot of stress. And you have a capability to deal with a lot of stress because of either the lockdowns, curfews, hotels, and the number of things that happen there. There's a lot of stress, and there is what kind of connection stress has with the heart disease, and what are your thoughts about what should people do to prevent stress affecting their hearts?
Well, stress is part and parcel of life, and if there's no stress, there's probably no life. But unfortunately, back home, it's been overwhelming, and the stress is over and beyond a usual, normal stress anywhere else is. Everybody has economic stress, but then the situation back home for last almost 3 decades has been unfortunately really, really sad, to say the least. And people have had PTSD and tremendous stress disorders, which are lots of times under-recognized, but lots of work has been done. And luckily, Kashmir is, in itself as an organization, has done a lot of work. We have our whole mental counseling thing going on and stuff to help that as well. But that the stress has direct effects on cardiovascular health per se. Besides increasing the rate of heart attacks and stuff, you can have stress cardiomyopathy, which is called Takotsubo or broken heart syndrome, as itself a manifestation of it, plus increasing the risk of progressive CAD and acute heart attacks. It has to be a very comprehensive process, and I don't think there is a quick fix to this stress relieving thing there. Let's hope things work out in a better way for all, and peace prevails and people are feel better. It's much beyond the discussion of this topic here, which are bigger issues, which may take a lot more time to resolve. But we can just, for the time being, deal with the effects of stress rather than the cause of stress from our point of view.
Yeah, that brings me to another area which has recently shown to affect heart and vascular system in a bad way, is COVID-19. And in fact, there was a study, MRI study, where almost like 60% of the people had some degree of myocarditis on the MRIs. Could you educate us a little bit more about how is COVID and heart connected, and what should people look out for after they have COVID to make sure that they take care of their heart in a better way?
See, COVID, unfortunately, has been a disease which has kind of gradually progressed as we started to learn more about it. Besides the obvious lung issues, heart is clearly very well involved, and vasculitis is a big problem of it. The way it affects heart, it affects the upper covering of the heart called the pericardium, causing pericarditis. Excuse me. Besides the muscle of the heart causing myocarditis, but besides that, it can give heart attacks also because it forms a lot of clots. It can give you clots in brain, causing a stroke. It can give you clots, which give you heart attack like any other heart attack. Unfortunately, heart attacks because of COVID are so much more difficult to deal with regular heart attacks because they have a ton of clot. And lots of times, early days in New York when COVID was rampant, um, it was a big problem. We didn't have a lot of cases then, but whosoever came with a heart attack because of COVID, the results were not the greatest because the clot burden was so high. Even balloon angioplasties and stuff, as much as good it is, was not the right choice that's the time. In fact, because of the infection risk, lots of time we resorted to giving thrombolytics at that time because obviously risk of infection, clot burden, but it has subsided to a lot of extent, at least here. In fact, besides the disease itself, now there is a lot of data with the COVID vaccines giving pericarditis and myocarditis as well to people. And I have people with COVID who have had pericarditis and myocarditis on steroids for a year and still getting pains off and on. So it's a new entity, unfortunately, affects randomly lots of people and not a particular group specifically. Some people do get heart involvement, and depending upon what part of the heart is involved, the management does vary from person to person.
Yeah, coming back to the awareness, which helps in prevention, early detection, timely treatment, and a 40-year-old having a heart attack can die right at that moment, or if you treat it right, like he can have another 30 or 40 years to live and see his grandchildren or their marriages and all that, right? So it has a huge impact on families. And how can JK Scientist platform be used by the healthcare to promote awareness? Like, what do you think like they can do to help us like bridge the gaps that are there?
See, I was just came remember that you have 12,000 members there, and these are young, educated people. And if they can spread the message around and use their social media presence and other things to spread the message about this while they're doing their own educational things, spread that this is a community effort to help and recognize early signs of heart attack, point out to how dangerous it is, how lives can be saved by early measures. Like one of the things probably that when you have symptoms of heart attack, just take true chewable aspirin, saves like one quarter of lives, 25% mortality prevention. If even that is put in, if you have chest pain like that, chew 2 aspirins. That's as good as giving a thrombolytic. So if these messages are carried out, this is the number to call. If you have heart attack, call this number, make them aware of symptoms of it so that people take it seriously. Because even in this country, our heartburn, as you said, it's sometimes totally missed as heartburn, and especially if you take a bigger meal. But recognize signs may be difficult. But if people err on the side of safety, there's nothing wrong in getting an EKG or going to hospital getting checked out. It may be overburdening a system, but at the same time, it saves lives.
Do you think there are enough heart doctors in Kashmir, or we need more heart doctors?
I think we always can use more. I think they're very capable, and now there are many medical colleges. Now you have 3 or 5 working cath labs in Kashmir. Besides SKIMS and SMHS, Khyber has a working cath lab, Nora has a working cath lab, Florence has a working cath lab. If these places, and I know a few other places which are putting in cath lab right now, if these places are well staffed around the clock, and then we have to go to districts like Baramulla, Kupwara, wherever, and Jammu, Kotwa, wherever. Now these new medical colleges, I think it's a shame that you build medical college and don't give them the infrastructure they need. So once you have a medical school, they should at least, cath lab is a bare minimum they can get, if not an open heart surgery program. They have enough people, and sometimes it's silly that these people, when I just worked in Sora this time, there were some post-DM students there who have great experience. They have worked in Apollo, they have worked in escorts, they have good hands, they have good knowledge. And now they're struggling to find a job. If they don't find a job, they're going to go to Middle East or somewhere.
Yeah.
Rather than as post DM cardiology, going to field and practicing bread and butter medicine, which is nothing wrong with it. But if they have trained in a particular thing, they better be utilized in that direction rather than being utilized to do seeing flu and other things, which there are enough people for.
You know, like you mentioned, there are a number of DM trainees there. Like my brother just finished the DM, and he is going to be an additional addition to the group of cardiologists there as he plans to stay in Kashmir. His name is Shahud Kakru. But one of my worries has always been that previously there has been a tendency by the administration, by the government, to put like a very skilled people to in areas like sub-district hospitals where their skills cannot be optimally utilized. What can we do to mitigate that, to kind of like get right people in the right place so that they can utilize their skills and help people?
See, good part is that some of these things have led to hospitals like Ranawari and sub-district hospitals do a lot of surgeries and stuff. And I'm very happy to see that, like, they do a lot of surgical work in these places. But again, in cardiology, at least if you have to do acute MRIs and stuff, you need a cath lab and you need infrastructure for that. If these places, like, forget about sub-district hospital, at least the medical colleges they build what, 5-8 medical colleges now. If they put 5-8 cath labs with them and they have enough trained staff to run them, that should be fine enough. Like, no, you will have door to balloon times minimal now. The person from Kupwara does not have to travel all the way to Srinagar for getting an angioplasty. He can get it in a closer place. So that will save time. Yes, again, as I said, that there definitely are enough trained people to, rather than lose them to Middle East or somewhere else, and people especially who are, hats off to them, that they want to stay back and contribute in those difficult circumstances. We all owe them. We can at least support them to do the right thing.
Like you mentioned, like if there's no professional satisfaction, that makes people look for solution outside the box, right? So if you think about Kashmir as a box, so you try to look for solution outside the box, and it can be the rest of the bigger cities in India, it can be the Middle East, it can be America, it can be England, and in the process we lose a like a really skilled person who could benefit people because we did not have right kind of setting for him to practice what he loves to do. And I have personally known like some of the neurosurgeons who were the brightest and got put in the subject hospitals and end up leaving, and we lost some really bright minds. And one of my recent satisfactions has been that there is a lot of tendency now. A lot of people do not think so well about that, but a lot of people, like I am one who thinks very well about that, is there are a lot of doctors who are trying to get in the administration. And so there is, and I think like what we remember, Shah Faisal was like, just like, I feel like we set the trend. And then there is Abid Shah, there is a number of other doctors who went into the administration, and I think they understand the both sides of, like, they understand the administration side of like what are the challenges there, they understand the medicine side of what are the challenges there. Could there be an effort to involve like them to get the best out of administration in terms of like how we can distribute the resources so that we can provide the best care with the available resources in Kashmir?
Oh, it's a long ask. There are so many people who want to do so much, and there have been kind of hiccups and roadblocks one way or the other. It's been dream of lots of people to build a health system there, which is world class, and it's my dream and lots of my friends' dream too. We have worked towards it to a lot of extent. In fact, we have a project in government's cell, which is kind of ready to go. And hopefully we don't get the same hiccups as other people did. We're trying our best to do it the rightest way it is possible. And if that happens, see, the system currently there, like as much as you push SORA or SMHS to do, it's a system for, like, if not centuries, at least 15 years, 20 years, 30 years. It's very hard to change the whole work culture in those places. Doing 10 cases, 20 cases one day is okay, but making it daily routine is not that easy.
Right.
So I have honestly believed that there has to be a parallel system which is run to the same extent as any other world-class system is. Meanwhile, there are incredible small hospitals who do a lot of work, like surgical work, especially cholecystectomy. And this system does not need to compete with that kind of work. They don't need to compete with cholecystectomies or hysterectomies or nonsense. This system needs to be geared at the high-end work for which people go outside, do bypass surgeries, cancer surgeries, high onco surgeries, chemotherapy of high grade, radiotherapy of high grade. The treatment, what people have to leave valley for, sometimes unjustified, but at the same time, like we just had somebody who had an MI, went to a local place, got an MI done and everything great. So I asked somebody from SKIMS, what is the reason, like SKIMS and SORA being pinnacle institutions, why do people want to go to a smaller place as compared to these places to do an acute MI when they get chest pain? His answer was because they want personalized care. They don't get that in those places. They want that room, they want the bathroom, they want the whole thing, And again, I had a friend's patient, uncle or whatever, in one of the small hospitals, and they were very reluctant to go to ICU because if you go into ICU, you will not have a bathroom, you will not have your own. There is this huge issue that the level of care some people want and deserve is not there. And the people don't blame the government system, cannot come up to that. So that's, I think, is a very, very important thing. And meanwhile, I'm not sure if most people know, now there is this gold card and stuff, which provides 5 lakh insurance for people. So money is becoming less of an issue, even from patient point burden stuff. So there's a lot you can achieve now. So even if somebody comes in who has nothing, has that gold card in hand, it's 5 lakh rupees. A family of 5 has 25 lakh rupee insurance. Is not available anywhere, I guess, but that's great. So these things can be achieved, and hopefully pray for everybody, and hopefully we achieve success in that, and that will be good for all of it. And the dream is that the same thing, people who will lose to Middle East, and when they are in mid-50s and their kids go to college, they all want to come back home and settle, and there's no job there. And they can practice the high-level medicine they used to practice elsewhere and be home as well. So that will raise the whole level of care back home, and hopefully we should be able to achieve that.
Yeah, like you said, the financial barriers was one of the major barriers how we could not do a whole lot previously, and now those gaps are closing. Now, that also opens opportunities for like a more advanced treatments, like we do here, mitral clips, Watchmans, TAVRs, that are, you replace the valve through the catheter rather than open heart surgery, and the patient recover in a day, like they're home next day. They don't have a long hospital stay. Very helpful to a lot of people who can otherwise be high surgical risks. And again, like there is not a whole lot that's happening in India. What my real question is that there are people like you, people like Dr. Alakaban, people like Dr. Riaz Bashir that are like really well placed in the training programs here. And what would be the barriers to get somebody from Kashmir and get them structurally trained so that they can go back to Kashmir and open this area of cardiovascular medicine to people and have people have access to this?
No, I think the training programs here are great, and lots of them are pretty well trained there. And but just kind of tweaking the skills a little bit and doing more, they should be able to handle it. It's not a big deal. Like, no, TAVR, as impressive as it looks, it's a very simple, straightforward
A simple
procedure.
procedure.
At the end of the day, and they already have done one in SCIMS, and it's just a matter of setting the whole stage up. Now, having a particular workup, the CTA, other things. Other companies helped tremendously with that, because I asked them what they did. Who read the CTA? The company did everything for them, which even here people are doing, but they have capable people there as well. They have somebody who has had 2 years imaging fellowship from Canada,
Mhm.
who look at MRIs and stuff in SCIMS. So
Okay.
there is no dearth of talent. It's the system which needs to be upgraded, and hopefully will be upgraded sooner or later. And especially if we have something outside the garment sector, which has its own, garment sector as good as it has its own limitations. They work on their own schedule, on the budgetary things, or who approves what and how does it go through approvals. With the private sector project, these things can work much faster. And I do not think that should be a limitation. Like, we have enough people here at well placed who can, if the need be for that kind of training, help that too. But most of them are really, really capable of handling it. With doing a few cases here and there with them should lead to 1 to 3. There should not be an issue.
So when you think about, like, you mentioned like really important thing, private setup in Kashmir, and I know there have been efforts before to kind of like build a heart hospital that did not finally go well, and you have done a lot of like pilot projects to, like, I think what you're doing is like really smart in terms of what we call in improvement sciences. You're doing the testing, and then you're seeing, like, is it like worth it, like before making a huge investment. What would be the barriers to building a heart hospital? And like funding is obviously the one, but what are the other barriers that will be there? Like, previously, like, I think one of the major barriers was willingness to pay for the service. Like, now, if people have gold card, that may not be a big issue, right? So what are the barriers now for a number of cardiologists there and cardiologists here and cardiologists across the world from Kashmir to collaborate and build one?
No, to be honest, it was not, the concept is not just the heart hospital. Concept is a state-of-art tertiary care center, which has everything, anything available. Nobody has to, hopefully people from all over other places come to that hospital for treatment, because we have incredible talent spread all over the world, and lots of them can come and be part-time or full-time working there. That is the goal. And goal of this hospital hopefully is, it's going to be a non-for-profit hospital. Nobody's going to make any money out of it. That would be the goal. And I think that's the hope I have seriously, that will give us that moral ability to do what we want to do faster, because whosoever invests money in it does not get a penny in return. It's just dumping money in it and letting the hospital, hopefully within, if at all, inshallah, it comes around, 5-10 years, it will be a self-sufficient place. It will, whatever money is made in, will be spent on upgrading the place. And hopefully by that time, we are bright enough and we have enough educated people around the world to think like places here, what do they run on? Endowments for people. And we have enough people around, and if they see a place which is working for the people and right, and I'm very, very sure most people will be more than happy to invest and give their money up to see it upgrade. It's just a matter of probably luck and getting things all right in one place. We're very hopeful. Let us see.
Yeah, I want to switch gears here and like touch briefly, because we're running out of time here. So I want to touch briefly on, there's so much focus on heart attacks, and we forget another important disease, the stroke. And there's a connection between heart and the stroke. And my grandfather had a stroke and had a disability in his last later portion of his life because of the stroke. And this is something like that can be prevented. And what can you educate us about the stroke that people can look out for before they can have stroke, what kind of heart conditions can cause stroke, and how do we prevent these strokes from happening?
Yeah, I think the commonest issue with stroke back home, with whatever I have experienced back home as well, is their hypertensive strokes. Most of them are bleeds, uncontrolled hypertension. And then ischemic strokes are ischemic strokes, obviously, which AFib is a huge cause and it's under-recognized and under-treated.
Mhm.
And because we don't have that kind of outpatient follow-up, and people don't take care until they get really, really sick. If somebody were in care and was noticed to have AFib, there was an anticoagulation that obviously will prevent a stroke. Otherwise, they will end up having a major massive stroke. The same way, if blood pressure is well controlled, the risk of having an acute hemorrhagic stroke would be definitely less. Meanwhile, if at all you end up having stroke, there is like an acute heart intervention, there is acute stroke intervention as well. And we have, thank God, trained neuroradiologists here, Kashmiris, who are well trained in doing that too. And they can definitely upgrade the system and train people there to do stroke intervention as well. It's again a matter of infrastructure, a matter of building up things. I'm not sure if they have a stroke interventionist there right now, but they have pretty good cardiac interventionists. And even in this country, the thought is that cardiac interventionists should do a lot of stroke because we have a lot more experience than these people do managing arteries and wires and stuff. But that can be done as well. That acute stroke intervention can be introduced as something which is very helpful, besides treating the cause and trying to prevent it, basically.
Right. Well, thank you like very much. I have like there are a few questions, but I want to like just read one of the questions here. Students and youth of Kashmir have been under stress for ages. What advice do you have for the students and youth to stay healthy, overcome stress and anxiety?
So again, I think we are in a situation where stress is part of normal life and much more than any other part of the world, probably. I see my little cousins and everybody else that they all are very bright and hardworking. Focus on what you have to know. I think the basic thing which I tell my kids is to figure out what you love the most. Try to go in that direction rather than like focus on wrong things. Like no, meaning if you want to be whatever, be journalism, be whatever, just go that way. Like although it's changing, but we had been pushed in one direction or other by parents, so you had to either be a doctor or engineer. It's changing a lot. Try to figure out where your heart is and go there, and you will definitely succeed. I have absolute faith in our youth. I think they're very, very bright people, and the sky is the limit. There's nothing. Just focus on what you want to do. There's no shortcuts. The stress is not going to be relieved in a day. It's unfortunately, our life, and we got to deal with it. There's nothing, and whatever help is available, please seek it. As I said, Kashmir has full. We have mental health professionals there, psychotherapists there. If you need to talk to somebody, we have a hotline for that. Utilize it, and whatever you need to do to get yourself where you really deserve to be.
Well, thank you so much for your time, and I really learned a few things at least, and more in the area of like your relentless efforts to make things, make situation, make systems better back in Kashmir, even if it's like a little bit of effort. Like I think it counts, and I think we all need to appreciate everything you have done so far, and hopefully collaborate even more in future to improve the situation.
Inshallah, I think it's your effort. This effort is huge effort from the whole system, and JK Scientists is doing a great job in raising the education level for students and bring them all up to date. As I said, I think bottom line is education in the end, and if we are able to educate our youth or educate our future, things will change automatically. It will take a little longer time, but there are no shortcuts to it. That should be the ultimate goal.
Great. Thank you, everybody. I'll turn it back to the organizers, and I think we will let them have the
Thank you so much, Dr. Mashood. We have a few more questions on our social networking sites. So Dr. Bilal, prioritizing some questions. Number one is from Dr. Saeed. What are the various career opportunities in this area of research, and what will be the advice for our future medical researchers?
See, there's in fact, before I went on this program, I checked with somebody from SCIMS as well, Imran, that I had an idea that they had somebody who was looking into these sudden deaths back home for the cause of so it's a great opportunity to look objectively into it. Why are we losing our youth, and what are the factors to get to know? It's easy to blame drugs, it's easy to blame stress, but objectivity in research kind of clarifies exactly what it is. It's a huge area of interest, and not interest, it's our necessity now. We need to get to the bottom of it, why we're losing our youth at young ages. And if that will probably show if there is anything we can do to prevent and help.
Okay, we have one more question. A number of people in our valley are on blood thinners or beta blockers, or some people are suffering from CADs. Should they go for a COVID vaccine? What would you suggest them?
No, COVID vaccine is a must for everybody, no question about it. There have been blood thinners, beta blockers, it doesn't matter. Everybody should get one. Whatever they get handed on, something is better than nothing.
So I think the rest of the questions have been dealt by you, Dr. Bilal. So we are also running out of time. I would like to thank you, Dr. Bilal, for being with us today. I would also like to thank Dr. Mashood for giving us time. It has been we have been immensely grateful to hear from you, and I'm sure that the people back home would be getting benefited through this talk. I would also like to thank Dr. Zahida Kamri for her untiring efforts in organizing this session. I would also like to thank Saima Beg and Dr. Mir Zohar Gul, who are part of our team for organizing this. So Dr. Saeed, the Director, JK Scientists, is with us. Do you have some final words, Dr. Saeed?
Oh, I'm impressed by hearing from these experts from our part of Valley. It has been a wonderful 1.5 hour session. I would like to thank you all, and the efforts you have been doing through Kashmir and personally in Kashmir are impressive. And in whatever way possible we will help. We are there for raising awareness and education. Thank you very much. Thank you.
Thank you, Dr. Saeed. So once again, I would like to thank Dr. Bilal Malik and Dr. Mashood Kakru for giving us time. Thank you so much, Dr. Bilal, Dr. Mashood.
Thank you for having us.
Pleasure.
Thank you so much.
Thank you.